Okay, trying to go in now, but he's still complaining, you know. A little bit. He's sedated. No, está sedado. Focus a little bit. Let's enter carefully. Okay, so Veru here on the pillars of the sphincter, you see them? You see the anatomy a little bit different, no? When you learn to recognize these pillars, you see how far sometimes the adenoma goes further down than the verumontanum. So this is a little bit big prostate, probably 120 grams was estimated, but that's not too big for HoLEP. We have the UO. One thing that is very, very infrequent is the duplex systems. I have seen very, very few cases. Complete system, do you know, duplex uni or bilateral systems, it's very rare. But sometimes you can find an ectopic ureter somewhere, and it's pain, no? It's a very, very, you need to recognize that situation if you can. Here you see that there's no outflow. Look, there's no outflow because the orifices are, let's say, not letting, the sphincter is closing over the orifices, so it's not letting the water go out. So if there's no outflow, there's no inflow. So you need to get in again, get some irrigation going, you see, and then you can go back briefly. This is a problem with the design of the endoscopes, you see. It's not well designed. The problem with enucleation, with enucleation instruments, is that enucleation has been a niche treatment for a long time. So companies didn't see the benefit in investing in developing good instruments for enucleation because it was only practiced in a very small number of centers. No? So I think we have a white line marked already. Let's go into the plane. Let's see if we can develop a space so we can have better irrigation. No? Let's start the procedure here. This is white. This is our entry into the plane. Let's see, it's sometimes you can go a little bit too deep and then you can correct later. Let's see, we have the entry in that side. Let's see this side now. This is the easiest place to find the plane, I think, or to find start the entry. Now we connect, and now we are going to try to start developing the posterior line. Let's see. Where do we find a nice depth of dissection that makes sense? It's not a very friendly plane, no? Sometimes you can find the plane doing a little bit of mechanical dissection, but you see, it's not detaching very well. There we are, going from side to side, trying to do a relatively smooth line of dissection, relatively continuous line of dissection. See how far can we take this. Some cases are more friendly than others, no? In this case, the plane is not very, very friendly. Let's go now to 12 o'clock here to start the ascending dissection again. There we are, coming here, deepening. You see we have the same problem with the visibility because the sphincter closes over the draining holes. Let's see if we can start the lateral line. Here also I have some little conflict with the leg. Okay. Coming up and down. And connect. Posterior line needs to connect to the lateral line. Here we don't go up further because when we remove the endoscope and we go to the apex, we see that there is, this is my white line, you see there's apical attachments here that need to be released. So I do this access incision. Sometimes we cut on the adenoma, you see. I'm going to cut, let's say, exaggerated. Normally I wouldn't do that. You see I did a cut, so all this tissue is getting out of the way, and now I can see much better, you see. Look, this cut was here, but I'm now going to follow the plane because now I can see very well, you see, where is the plane, thanks to this access cut. Huh? It's not a cut that we do trying to follow that cut later on for dissection. It's just, it gives us access to see. You see here, now we can see anteriorly, we can see where this wants to go. Here's the 12 o'clock that we marked with our white line, and here this is the anterior plane coming up. You see we can go all anterior as much as we can. We cut the apical attachments and then we try to develop more of the lateral line and even a little bit more anterior line. We want to have more mobility, so I need to detach more, a little bit more, so we have more mobility of the adenoma and we can you know, get better access to the anterior also here. Let's see. Now, 12 o'clock. This is our white line again. You see, we did a mark and it's helping us now to recognize where is the sphincter. It would be very difficult to recognize where is the sphincter. Once you start the operation, I think you can get very confused because as you mobilize the endoscope inside carefully, the sphincter gets relaxed. You know, it's like doing an anal dilatation. When you do an anal dilatation, initially you can only put a finger, then you put two, then you put three. So I think at the beginning of the operation, the sphincter has a lot of tone, but as we progress, we start moving the endoscope around, the sphincter gets much more relaxed, you see? So it's much more difficult to see where's the limit. Here again, you see when we come out, we see that there is apical tissue. This is all white, so we can stay there following this white line that we marked. You see we incise a little bit. This gives us good access, and then we have to decide where's the good plane, you know, how deep we have to go. Let's see, this looks yellow. I look a lot at the color, you know, because yellow color usually means adenoma. Not always, but most of the times yellow means adenoma. The capsule is whiter than the adenoma, which is more yellow. Okay, here, so we are progressing a little bit, getting mobility, but here we still need to go around here. Try to stay horizontal now. When you go below the sphincter to try to remain. You see this could be an access incision as well. You see, and I want to go up here around this nodule, this yellow tissue. If I can, and gain millimeter by millimeter, I want to improve the situation, I want to improve the access. Okay, you cannot do a forceful dissection trying to go around this nodule. You know, you want to do small improvements in dissection, progressive mobilization, you see, trying to develop a good plane that will finally let you do what you want to do, no? Here coming up and around, we still have some yellow tissue there above. Let's see. It's probably getting closer to the 12 o'clock region. There's no help from the patient. He's not helping us. If that looks yellow, we can go below it, try to see if we can find a better capsular plane. Sometimes when you do that, you can realize that you're going too deep, and then, okay, so you have to go back to the previous plane. But here you see, now I'm trying to reach closer and closer towards the 12 o'clock area. In this case, maybe my line is not so perfect, so I'm going to try to spend a little bit of time trying to do a better line. that I can then recognize better. And here we have the 12 o'clock tissue. Here, you see here we are taking this plane, which looks quite good. But when we come to the other side, we realize that there is some discrepancy. Just connect. At the end, we want to remove the orange. We want to take the orange out towards the bladder. So it's never very difficult. You need to think, what can I do to connect those two apparently different planes? No, it's usually just connecting them by cutting whatever is separating them. I'm always thinking that the objective, the final objective, is to push the adenoma into the bladder. So there we are, coming up. Coming up and down, let's see. And around, no, we want to go around. Let's see this side, maybe here now we can do a little bit more of the lateral dissection. You see how I am touching the tissue a little bit more, because I think the plane doesn't detach so naturally, so easily. So I need to do a little bit different distance. So the distance that I'm using with the fiber is getting me much closer to have a much more disruptive effect, because I want to be able to progress. Otherwise, the plane will not give so easily. No, so that's how you adapt the energy usage to the case. No, we want to progress carefully. You see, we've gone quite anterior here to try to make sure that we remove everything. And now we have to look down because we want to reach the bladder neck. If you are, let's say, very afraid of entering the bladder this way, you know, of course you can take it as close as you can to the bladder neck. So trying to progress, you know, slowly and carefully, try to get closer and closer. But if at the end you are afraid of entering the plane, there's a trick that I'm going to show you. So, because I am very used to seeing these anatomies like this and the bladder neck, and sometimes I can tell that I'm reaching very close and I know more or less what to expect. But when you don't have a lot of experience, you might be a little bit more anxious to just continue digging here. You know, it starts to look a little bit, how do you say, deep, and you don't dare to continue, no, because you see it's starting to look deep and you're not comfortable. No, you come here, what is this? Am I going to perforate or what? No, so what you can do is you can go inside. Again, you see, you go inside the prostatic urethra and you try to cut here. Okay? You do a cut like that and then you return. Here, you see? This will confirm, okay, that you are good to enter. It's a very simple idea, no? We know the anatomy. This is how, I mean, at the beginning you're a little bit scared to do that. You don't want to do something that has no easy solution, you know. So then over time you get more and more confident, and then, you know, you just trust this look of the bladder neck, trust this sign of the whale. We call it the whale, the sign of the mouth of the whale, no, because these lines look like the mouth of a whale. Or, you know, there are many ways to call that. There we are. They're coming down the bladder neck and trying to connect. You see what we had with the rest. Let's see if that's a better plane, maybe. Sometimes we can go slightly deeper there and find a good plane still. We find that we can remove more tissue. You see, this plane doesn't look anywhere near the other cases we saw today, you see? And you will find cases, I still find planes that I think I never saw something like this, you know? For some reason, the tissue looks, the look of the tissue is highly variable. And then you need to think, okay, is this more or less smooth? Does it look like the capsule, you see? Is it how do you say, coherent, smooth, mostly white? I mean, in this case, everything looks yellow, no? But it looks capsular to me, you know? Is it perforated? No. Okay, so it must be a good plane. That's what we have, no? With this, we have to work. Not all, and I tell you something, when I started with green light, I started doing enucleation with green light, and I was doing mechanical enucleation with the endoscope, you know? I was dissecting with the tip on the endoscope, sliding the tip over the capsule, like if it was my finger, no? Trying to do an open enucleation, and then I would use the laser to coagulate and to cut some, you know, fibrous breaches of tissue that, you know, I saw that I might better cut with the laser rather than try to dissect force, you know, with force, with mechanical action of the tip of the endoscope. And you know, I was always a little bit concerned when I was doing this enucleation with green light. I was always a little bit concerned that the plane might not be good, you know. Sometimes we found planes that developed really, really nicely, but sometimes the planes were horrible. And, you know, I started understanding when I started doing HoLEP that with energy dissection, you see, even when the plane is very bad and it doesn't detach very nicely, you can find a plane, you can follow a plane, you know. And vaya, se paró el vídeo, macho. Maybe, no, I don't know why. Stopped, maybe the memory stick was full or something. Okay, so you see, energy allows you to work these planes much more safely, I think, than trying to do mechanical. You see, when the plane gets very thin, we can navigate very carefully. We can target the laser towards the adenoma, and we can progress quite well. And doing this mechanically was very, very scary, you know, it was very difficult. And that's the problem with all the mechanically based dissections, no? When you do, I think, also by HoLEP, of course, you can use the energy also to try to break, no, find the plane, but I don't think it's so easy. Here, you see, we see that we got some depth, not too bad. It's a small perforation there. I don't know if I did it with the laser or when I was pushing the capsule. Sometimes it could be a laser, I don't know. There we are, trying to continue our dissection now. As we open the bladder neck in both sides, the objective is to go from 12 to 6 in both sides and to connect here below. So I'm seeing that this lower plane can dissect quite well now that I have liberated the lateral aspect. So I'm going to continue a little bit like that, and then we will see what happens laterally, how close we are to the bladder neck area, how much can we dissect here. Sometimes we have to negotiate these angles like this, you see. So coming up, coming down, trying to continue. Trying to join the lines, you know, keep the lines going wide You see, trying to connect. Let's see. This is posteriorly, I think we are quite advanced. See, I try to keep the fiber more close to the anterior. Here, this is the zigzag technique. When I come to this side, I go up, and I continue towards the other side. And when I finish this, and I want to change direction, I go up again. You see? So this is how you negotiate the posterior plane, trying to go up as you go, no? Trying to get closer and closer to the side of the adenoma, because you want to peel, you want to cut the fibers that join the adenoma with the capsule without deepening too much in the capsule, into the capsule. So here, let's see, we are getting closer, I think, to the bladder neck area. Let's see. Let's get that connection coming from the side towards the middle, like that, from the side towards the middle. This is normally a good way to navigate the posterior plane. Try to go from the side like this, and then come to the other side and do the same. Here we can see where the plane is going, so maybe we can continue detaching a little bit here. I can see some depth, so we need to keep further up. You see, we can negotiate and we can be precise with the laser. We can do what we want. So this precision is allowing you to go even when the capsule is thin, even when the plane is difficult, we can progress quite safely. That was a mistake. I lost control for a moment, you see? That's why you have to try to be controlled all the time. In this case, I think there was like a little step and the fiber jumped and it caused a little, like this. So try to move slowly and to try to control the laser to avoid these little problems. Let's see, here, and down and up. Now, I think we can push this lobe into the bladder. This will open up this plane a lot. And then when we reduce the hinge, la bisagra. I think it's hinge, no? Bisagra. Let's look inside the bladder to see where's the UO. Where's the UO? Here, not so far. So we're going to cut a little bit here, trying to stay a bit medial. UO is now lateral to where we are, okay? And let's see in this side what happens. Bladder neck, UO, lateral, so we can finish comfortably here. So I don't know how long it took, but it was like 25 minutes or something, no? Not too much. I was able to navigate a difficult plane quite efficiently by working continuously. See, now it doesn't look so bad, no? The plane. Let's do some hemostasis. Okay. There's some bleeders here apically. It's pretty good. Sometimes you can try to be a little bit more aggressive maybe, and remove this little bit of tissue. It's difficult to say sometimes which is the right plane. I think we have removed the adenoma quite anatomically, but sometimes we find this little bumpy tissue, and you can decide to trim it, to cut it. Sometimes if you leave anterior apical tissue, you can have a little bit of growth, and then you have an obstructive problem. It's maybe not, huh? I don't know. Some people are not very concerned about leaving tissue because they think they did a quite big fossa, and they look at the statistical, let's say, possibility of the patient returning with problems after such a good resection. But I remember one case, he had a 100-gram prostate. No, we took out 100 grams. And he had like 2 grams of tissue remaining at the apex, and he got obstructed. And I remember I did an ultrasound after the operation, and the cavity was super huge. So I was very impressed. How is it possible that 1 gram, 2 grams of tissue left near the apex would behave so obstructively, you know? And so I reoperated the guy and I took the tissue. Then he developed prostate cancer after time. So that's why I'm a little bit, try to remove everything if I can. I think you can try to remove everything, and it can be as safe as, and probably more safe than leaving tissue behind, because sometimes patients bleed when you leave residual nodules and residual tissue. So, vamos a morcellar. Let's morsellate, no? ¿Estás lista? Okay. You good, and you good. This is good. I think there's not much tissue left. Let me show you one thing. ¿Habéis apagado? No. So when the prostate is like this, it's very hard. You can go in with the laser and do some cuts on the surface. You try to cut and make it more irregular. It's moving around too much. But you try to make it more irregular. You see, you do some cutting on the surface because it looks like very hard tissue. So this way you enhance the morcellator grasp, no? So some people do this systematically, some people do it sometimes. In this case, it felt maybe a good idea because you see, the morcellator likes the irregularity. It doesn't take long, you know. Okay. You understand the concept. Tira fuerte. Ahí, con decisión, ¿sabes? Es chaca. Para adentro, vamos allá. Venga, morcelamos. Suelta, espera que lo suelte. A veces se engancha un poco. Muy bien. Okay. Now, back to Morsellation. Voy a enfocar. I'm going to focus. You see, it's very difficult to grasp this tissue because it looks a little bit hard. So it's going to be useful to have this irregularity. No sé qué pasa, está todo mojado el pedal, ¿no? It's not so easy to grasp it. Que está mojado todo, está horrible, no tengo el pedal controlado. A ver. The floor is wet and the pedal is sliding away from my feet, from my foot. So you see here I have the risk of absorbing too much water. You know, if the morcellation is not efficient, if the attachment is not good, I might be sucking too much water and the bladder will get progressively, let's say, less full, no? So you see the pressure goes down, the bleeding starts, and the visibility is compromised. So I pause for a moment to refill, and I wish I had a second inflow, you know? Mostly, in every case, almost in every case, I'm okay with that, but in some cases, you miss the second inflow. Let's see. I could tell this tissue was like more hard, no, more difficult. The plane was not so nice, so we had to cut through. Sometimes sculpt our way through the plane. Very slippery. ¿Qué settings tenemos, sabes? Let's feel the bladder again a little bit more. This is the fossa. Visibility is not too bad, but it's getting worse. The problem with the bladder when it empties a little bit is that it gets more floppy, so the suction can get the bladder because it's more elastic, is not properly distended, so we need to be careful. Morsellation has its rules. There are some rules of morsellation. I want to see if I could bring it into the fossa, but it's not coming in so easily. Let's see. Again, you need to be technical. You need to have a technical mentality and see what you can do. Try to progress safely. It's coming along better, I think. Now I brought it near the bladder neck. Maybe we can slowly bring it inside the fossa. But the blade is away from the bladder now. You see, it's now more in the fossa. There was some clot in the fossa. You see, when we enter, the visibility decays quite a lot. But I'm totally not moving myself, so I'm remaining in the same spot. Hopefully, the blood will be washed out. We can get to see a little bit better. So sometimes it's a challenge, but you need to adapt to the degree of difficulty with more, let's say, technical domain, more technical, prowess. I don't know how to say. You need to be excellent on how you use the instruments, how you position yourself to try to complete the morsellation. Again, if you are less experienced, you're going to tolerate less bad visibility. So, with experience, we can sometimes morsellate with not so good visibility. But of course, you don't want to take this to the absurd. We finished. This is sphincter. Bravo. Nice, huh? Nice case. Muy bien. Muy bien, ¿eh? Fenómeno.